Okay, here is care plan number 2. I chose a 87-year-old female who was booked for a nail fixation of her left hip fracture post-fall in the shower. She had no allergies and previous surgeries for humeral ostomy in 2010, had no problems with general anesthetic. So for patient considerations, she does have age-related considerations, which include some sensitivity to CNS drugs, risks of delirium. She also has risks of blood pressure liability just with vascular stiffening. She might have decreased respiratory reserve with chest wall stiffening, decreased elasticity, an exaggerated response to CNS depressants or respiratory depressants. She might have decreased function of her hepatic system, which slows the metabolism of IV anesthetics. She might have a decreased GFR, which then we need to be careful with our fluid administration or nephrotoxic drugs. So those are just some age-related considerations, specifically for this patient. CNS-wise, she is appropriate. She didn't lose consciousness during her fall or bang her head. There was a CT spine, head and spine that didn't show any abnormalities, no fractures, no bleedings. CVS-wise, she does have moderate aortic stenosis, which then we do have to consider her blood pressure and late dialysis. For respiratory-wise, she was an ex-smoker, but she quit 26 years ago. She does have spirometry, which shows obstructive disease. Her FVC-FEV1 ratio is 48%. Her spirometry shows that one test shows that she's responsive to bronchodilators, and the other tests show she isn't. So it's kind of a question of COPD or asthma or both. She doesn't have diabetes, no thyroid diseases. For her physical assessment, she lives in an assisted living community. She's able to do all her own care. She does require a cane for walking and uses a scooter for longer distances, but she says that she doesn't have issues with shortness of breath on exertion. For medications, she takes diltiazem, rosuvastatin, enoxaparin, and hydromorphone right now for PRN. Her labs all look normal. Her hemoglobin's 131. GFR is 52, and she's COVID negative. No other abnormalities with her blood work. Doing an airway assessment, she does have a little bit of a stiff neck with extension. Her Mallampati score is 2. She has a full set of dentures, which she will remove. Thyromental distance is normal. Her chest during the initial assessment is clear with no wheezing. So for this patient, when she was brought into pre-op, she was complaining of chest pain and she was tachycardic. Her saturations on room air were 80%. So she was given 6 liters nasal prongs, and the physician that had seen her initially gave her phenylephrine to try to increase her blood pressure and then hopefully bring down her heart rate, which did seem to work a little bit, but she was still quite tachycardic. There was some concern with her aortic stenosis, but it was also likely just anxiety. So we decided that we were deciding between spinal and GA, but we decided to go for a GA just because of positioning for the spinal would be painful. She was already very anxious, so we didn't think that she would be we didn't think she would cooperate for the spinal, and there was also a language barrier, so we thought the GA would be most appropriate. We also discussed doing an arterial line pre-induction. So we gave her some preoperative salbutamol via MDI to optimize her lungs. And then once we brought her into the OR, we did give her a fentanyl bolus just to calm her down, to allow us to put in IVs in the art line. So we put in an 18 gauge IV and as well as an art line to monitor her blood pressure, as we suspected that she would be quite labile. And then we removed her dentures and pre-oxygenated her with 100% O2. She was given 1 of Midaz and 50 of ketamine, and then propofol was titrated slowly to avoid any major dips in her blood pressure, and then was given 50 milligrams of rocuronium. So at this point, she was positioned with a roll under her shoulders, and after 90 seconds, she was apneic, so we assessed her for intubation. We used DL with a MAC 3 and a number 7 ETT. We saw a grade 1 view with using burp and intubated her on first attempt. We confirmed it with chest rise, misting in the tube, and end-tidal CO2, and the tube was secured at 19 at the gums. So then after intubation, she was maintained with SIVO. We kept her at just below 1 MAC, adjusted to her age. She was a little bit labile with her blood pressure, so we were able to give her boluses of 100 micrograms phenylephrine as needed. And then for the majority of the procedure, she was pretty stable. For PONV, we did give her ondansetron and dexamethasone. And then once it was time to reverse, we used Sugamadex, 200 milligrams. Oh, and I forgot to mention, for warming, we did use an upper body warmer as well as warmed fluids, but we were more reserved with our fluid administration. So once we reversed her, we did have some difficulty switching her over to a spontaneous mode. She was kind of coughing and wasn't able to take large enough tidal volumes. They were around like 50 mils or less. We listened to her chest and found out that she was wheezy throughout, so we gave her 8 puffs of Ventolin through the circuit, and eventually we were able to extubate her. We put her back onto 6 liters nasal prongs and transferred her to PACU. We decided, because of her cardiac history and her preoperative chest pain, to order tropes, and then Ventolin PRN for PACU as well. We did get a call back later in the day that her troponins were elevated, so we did a repeat, and from that point I wasn't following the patient anymore.